Blind spots, what are they and why should you care? Have you ever heard about blind spots in our healthcare system, things that we're just overlooking? This is one of the more important parts, I believe, of my book, UnCURABLE, From Hopeless Diagnosis to Defying All Odds, that I talk about in the book. And Marty McCary has actually written a book called Blind Spots. Great book if you want to take a really deep dive into this concept of blind spots. But the idea is, what are things in our healthcare system that we think to be true that actually aren't? There's been multiple examples in the past. Ignaz Semmelweis, over in, I think he was a Hungarian over in Austria, when he found hand washing was the difference between women having children that lived and dying, he started recommending hand washing and literally lost his career and ultimately his life catching the infection he was trying to prevent with hand washing. Crazy story. Smoking in our country, tobacco use. I'm from Virginia, and back in the 80s, late 70s, early 80s, it was controversial if smoking was bad for us. Back in the 60s and 70s, we knew it was good for us. My doctor smokes Camels kind of thing. And then the 80s, old smokers' rights, right? The early 90s, like, you have the right to smoke indoors kind of thing, or on planes, et cetera, et cetera. We got that wrong, one so wrong, and it took over 50 years and 7,000 research articles before the Surgeon General of the United States said smoking causes cancer. So my point is, what are blind spots now? I talk about a couple in the book. One big one I talk about is medical error. When I was in medical school, I learned that iatrogenesis, or things doctors do, it was the 5th most common cause of death, medication complications. Well, what we've learned now is that's deeper than that. 30% of all medications are toxins to your mitochondria. They affect your gut microbiome. Half of all pharmaceuticals are detoxified through your gut microbiome. So just medication side effects alone is a big player. There's actually a list of drugs that are high risk in the elderly that we're not supposed to prescribe that Medicare and CMS recognize as concerning. And now we're just learning that antibiotics in childhood increase childhood obesity, increase asthma, eczema. We've known in agribusiness that antibiotics make animals fat because they're commonly put in animal feed to make cows fatten up quicker and chickens fatten up quicker. It's common knowledge that antibiotics actually make animals fatter quicker. Do you think it does the same thing to humans? We now have literature to say, yeah, it kind of does. Increases incidence of metabolic syndrome, a bunch of things. Is that a blind spot? When I was in my training, we gave antibiotics out like candy because there was no downside. Another medication example is ciprofloxacin, which is something we used a lot. Used to use it all the time in the ER for people coming in with UTIs. Great drug, but lo and behold, some people, because it is a mitochondrial toxin, would have developed chronic fatigue, get floxed. You want to Google something interesting or AI something, being floxed by cipro or levofloxacin is a thing where you develop this almost like a chronic fatigue fibromyalgia kind of thing. You can have tendon ruptures. So the question becomes, are there other blind spots? Medical error, is it more than just medications? Is it surgical things? Well, the thing about it is because our current health administration does not recognize medical error as a problem, just like we don't recognize aging as an illness, it inhibits direct study of things we don't recognize. And so you have to look at secondary data points, Medicare, actuaries of people dying, what they died from, which is where in the book Blind Spots, Marty McCary, and also where when he published literature, I think he published in the British Medical Journal. It's actually footnoted in the book. They had to publish it outside the country because our healthcare system in the journals here don't see medical error as a thing. It's hard to say that medical error is the 3rd most common cause of death in our country because it's not quote unquote proven, but if 250,000 people a year and the elderly are passing away from medical error, then that puts it like right there at number 3. And the thing about, I think, is if you include the entire country, is it actually number 2 or 1? Great question, controversial, don't want to go there, but the question, we should look at this and determine how to minimize medical error as a issue. Another big blind spot, hormones, bioidentical hormones. I talk about that in the book. There's so many things we've gotten wrong. So the question becomes, does our system, does the practitioner you work with recognize that we don't know everything? Half of all, this was from Dr. Ioannis from the PLOS, which is the largest online journal in the world, put a nice article out there, also footnoted in UnCURABLE, that 50% of all published research articles are later found to be false. So when people talk about evidence-based medicine and following the evidence, following the literature, the following stuff that could be wrong half of the time. That is insane if you think about it like that. And so how do you know what the right stuff is? You have to season science, quote unquote, with clinical experience. A doctor who's been practicing for 20 or 30 years is going to know, yeah, that doesn't work. I've tried it. Yeah, that works. I've never read an article about it, but I know it works, right? That's kind of how I connect the dots between hypermobility, severe form being EDS, and a whole host of other medical issues before I started reading about it in the literature. That's also how I started seeing long COVID before it became a thing. Back in May of 2000, I saw my first long COVID patient. when we knew there was no such thing, right? Of that, if you all remember that. Being open to this and realizing our system has blind spots, and we have to be open to the idea that we don't know everything, and the data can sometimes deceive us because there are biases in research publishers. There's also biases in editorial boards. Something a lot of people may not know is that an editorial board is the board that determines what gets published in the journal and what doesn't get published. If someone has a crazy idea that vitamin D can lower your risk for cancer or lower your A1C, well, that's kind of weird. Who would publish that in 2000, right? They won't publish it. The editorial board will say, we do not agree with this, we do not publish it. So there's this slow creep. There's a saying that science and medicine advance one funeral at a time. And it's really true because you have to get new thinking, new ways of thinking. And it takes decades. I think the most recent thing I read, it takes between 20 and 30 years for new research to make it to your clinical practice. So with all these things, you really need to work with someone who's reads a lot, who's been seasoned clinically, practiced at a lot of different places, if you want to avoid medical error. And then you have to be your own advocate. This is something you do talk about in the book as well, and make a big part about being your own advocate. In today's world with AI and with access of all this information, the average person now can have a grasp on their health more than they could, 10, 5, 3, even 3 years ago with AI, even 2 or 3 years ago. You can go to your doctor's visit knowing, hey, I think this is what's going on. This is why. These are my symptoms. These are the most important things. This is what's going on. And literally present yourself. It's really interesting when I did my training. Hey, this is a great idea. Oh, I love this idea. It's great. Present yourself to your doctor. I used to do this. In our training, we did this all the time where interns would take a physical exam on a patient coming in the hospital. I had no idea what's going on, but I got good at a physical exam and I got good at the history. I'd present this patient with shortness of breath and swelling of their ankles and puffiness of their face. And to my resident, and they go, oh, it's heart failure. Do this, this, and this. I would have no idea what was going on, but I would present the patient to the resident, who then the team would present it to the attending the following day. Learn to present yourself to your doctor. Learn to research. Learn to say, what I am a XYZ. I've got these symptoms. To present your history, to present your timeline. That in itself could be if that's all you get from the book, present yourself to your doctor. That could be a powerful tool to you with your health. So I actually love that idea I just came up with while I was talking. Brilliant. Present yourself. Present yourself to your doctor. And if they're adverse to it, if they're negative to it, you need to find someone who'll work with you, someone who's going to be your advocate, but also come alongside you and be willing to learn with you. And in today's day and age, we need to realize we don't know it all. We can't know it all. I have medical students that come with me. It's interesting. He was telling me about one of the neurosurgeons at the university, talking to him, saying, these are the hands of God. And the point of that is we still have hubris and pride in our healthcare system. And as a patient, you just need to recognize which is skill and which is hubris, and avoid the hubris and go to the skill. Anyway, I hope this is helpful as you kind of go through UnCURABLE from hopeless diagnosis to Defying All Odds. Hope these little deep dives help you get a little different perspective on the book and learn more about things you can apply to your health to be the best version of you that you can be. Take care.